Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. If we look to the anatomy of the retina is formed of 10 layers. If we look to the anatomy of the retina is formed of 10 layers on histopathology, and depending on the level of the hemorrhage which may occur in retinal vascular disease, the shape of the hemorrhage appears. If we get hemorrhage in the superficial nerve fiber layer, this produces flame-shaped hemorrhage. If we get hemorrhage in the outer plexiform layer, this gives us dot and plot hemorrhage, which is very characteristic in diabetic retinopathy, and the retinal vascular or frame-shaped hemorrhage is more characteristic in the retinal vascular. To classify the retinal vascular disease which may occur in the retina, we have venous occlusion, arterial occlusion, which is divided into branch, cilioretinal central, hypertensive retinopathy, sickle cell retinopathy, retinopathy of prematurity, retinal telangiectasia, like idiopathic juxtafoveal or Leber's-Millery, cause disease, retinal arterial microaneurysm, and radiation retinopathy. To predisposing factors for retinal vascular occlusion, it occurs age, hypertension, diabetes, abnormalities of coagulation. Locally, raised intraocular pressure and peripheral bitis is another cause of retinal vascular disease. The pathophysiology of retinal vascular venous occlusion is started by stagnation, which leads to hypoxia, and this hypoxia leads to edema and hemorrhage, increased extravascular pressure. Again, this increased extravascular pressure presses hard on the venous tree, producing more stagnation, and this passes into the vicious circle. The signs of branch vein occlusion includes venous tuberosity, dilatation, flame-shaped and dot and plot hemorrhage, cotton wool spots, and retinal edema, as we can see in this fundus photograph in the right eye of a patient with branch vein occlusion. The prognosis is usually good, with a visual acuity of 6/12 or better after 6 months in 50% of the patients. However, there are some complications, including chronic macular edema and neovascularization. The diagnosis comes from the last century, in which we were using the fluorescein angiography, which is a dye injected in the antecubital veins and circulates inside the body till it reaches the eye, and then with a rapid sequence camera, it photographs the fundus during the transit of the fluorescein. So we get early fluorescein, in which the fluorescein is passing through the arterial tree, through the capillaries, and lately through the venous drainage. And if you have damage in the venous system, we get leakage in the surrounding tissues surrounding the vein occlusion, and we get what we call late hyperfluorescence. However, since 2004, there came a new modality of diagnosis for the retinal vein occlusion and all the retinal disease, which is the OCT, which is an optical coherence tomography. And this OCT depends on light passing to the retina. This light is reflected from the retina to a computer system, a camera system, which analyzes the picture and gives us like a histopathological appearance of the retina. Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. And we get this picture from the fundus, which is really like a histopathological appearance, with the layers of the retina, the 10 layers of the retina, seen on the photograph, starting from the retinal pigment epithelium till the nerve fiber layer. And this gives us a very nice picture of or analysis of the retinal tissue, including the vitreoretinal relationship, the attachment of the vitreous to the retina. Bismillah. Again, if there is advanced macular edema in the center of the macula, then we get cystic changes in the center, which as you can see, destroys the neural tissue of the retina, including the photoreceptors, and the patient gets drop of vision due to these cystic changes in the center of the fovea. Bismillah. If the vein occlusion passes into a long-standing vein occlusion, then we get vascular sheathings and collaterals. And collaterals are type of a defense, self-defense of the retina against the venous occlusion, like what occurs in the heart, trying to bypass the site of the obstruction to pass blood to certain areas of the retina. Uh, these collaterals are a good healing process of the retina. However, this is different from neovascularization, which is abnormal defense mechanism of the retina, which may bleed or induce fibrosis. Again, there are hard exudation which appears in the center of the fovea, leading to drop of vision. If you perform fluorescein angiography for cases with late macular edema, we may get areas of non-perfusion in which there is no treatment for that. However, eyes with good macular perfusion with a visual acuity of 612 or worse, consider doing laser photocoagulation or the new modality of treatment, which is injection to decrease this macular edema. Bismillah. Again, the treatment of macular edema is nowadays by anti-VEGF, which is anti-vascular endothelial growth factors. This anti-endothelial growth factors of anti-VEGF enter to the retinal tissue and decreases the edema and the leakage. Bismillah ar-Rahman ar-Rahim. Today, our lecture is about retinal vascular disease. Again, this is a still image of the procedure of injection in which we stick a needle into the pars plana 3.5 to 4 millimeter from the limbus, and we inject the material inside the vitreous cavity in this patient who is pseudophakic, as you can see, and this induces regression of the edema and the leakage. We inject anti-VEGF, or sometimes we inject steroids, as you can see in this still image of the eye. Bismillah. If the patient gets neovascularization, we start applying laser. The idea behind the laser is to destroy the ischemic areas, which produces substance which leaks inside the eye, inducing neovascularization of the retina. And this neovascularization are very bad defense mechanism, which can leak or bleed or induce fibrosis and retinal detachment. And as you can see in the right-hand side of the fundus photograph, there is laser application to the area of ischemia to decrease the production of neovascularization. Bismillah. If this neovascularization bleed or induce traction detachment, then the solution is a vitreous surgery in which we insert very fine instruments into the vitreous cavity to remove the hemorrhage, the fibrosis, and to reattach the retina inside its place so that the vision can improve. Again, if there is dense subhyaloid hemorrhage due to the complications of the neovascularization, we go for vitreous surgery, remove the vitreous and remove the hemorrhage so that we give a clear media for the retina to work. A more widespread spectrum of the disease is central retinal vein occlusion, and it can be non-ischemic in which the visual acuity is good. There is mild afferent pupillary defect, mild venous tortuosity and dilatation, mild to moderate retinal hemorrhage, variable cotton wool spots, mild to moderate disc edema, chronic macular edema, guarded prognosis, and may subsequently convert to an ischemic type, which is a bad prognostic sign. Again, if you perform fluorescein angiography for non-ischemic central vein occlusion, we can find that there is good retinal capillary perfusion, which indicates that the patient may regain his vision following this instance. OCT can highlight the degree of the affection of the macula, in which we can find cystic changes and sometimes epiretinal membrane formation. If we look to the other type of central retinal vein occlusion, in which is ischemic type, the visual acuity is very bad. There is afferent pupillary defect, which is marked venous tortuosity and engorgement, extensive retinal hemorrhage, variable cotton wool spots, severe disc edema, macular ischemia, very poor prognosis, and one of the worst complications of ischemic type of central retinal vein occlusion is that it's complicated by rubeosis iridis, which are new vessels which occur in the angle of the anterior chamber and on the surface of the iris, and the patient may lose his vision not from central retinal vein occlusion but from the secondary glaucoma, which is called glaucoma inversus due to the neovascularization on the surface of the iris. Fluorescein angiography of the ischemic central retinal vein occlusion shows non-perfusion of the capillaries, and as you can see in these photographs, there are multiple areas of black or non-perfusion of the capillaries, indicating that there is severe ischemia of the retinal tissue, which may end by severe visual loss. Again, if you look to the angle of the anterior chamber or on the surface of the iris, we can find new vascularization. This new vessels closes the angle and induce secondary glaucoma, and the treatment is application of pan-retinal photocoagulation, in which we apply laser to the retinal tissue to destroy the retina tissue, which produces a substance or material which ends by new vascularization on the surface of the retina. Another variety of the disease is papillophilippitis, in which there is mild affection of the retinal veins and usually occurs in young individuals. The visual acuity is slightly decreased, the afferent pupillary defect is absent, venous tortuosity and dilatation, variable cotton wool spots and hemorrhage, severe disc edema, and very good prognosis in 80% of the patients. Now we shift to the second cause of retinal vascular disease, which is arterial occlusion. And arterial occlusion may occur due to emboli or vasoobliteration. And the source of the emboli may be from the heart in the form of calcium, vegetations, thrombus, myxoma, or from the carotid in form of cholesterol, platelet, or emboli, or fibrinoplatelet. The cholesterol emboli or Hornhorst plaques may be in the form of multiple bright refractile crystals, often located at the arteriolar bifurcations, frequently asymptomatic. The fibrinoplatelet emboli occurs in the form of multiple dull gray particles, occasionally fill the entire lumen, may cause amaurosis vigox, and occasionally permanent obstruction. The calcific emboli are usually single, white, close to the disc, and may cause permanent obstruction. If we look to the causes of retinal artery vasoobliteration, it may be due to atherosclerosis or periarteritis. And you can see in the left-hand side picture of the fundus the classic appearance of the cherry red spot. And this cherry red spot is due to the necrosis of the retinal layers surrounding the fovea, leaving the fovea, which is only 3 layers, showing the transparency of the choroidal circulation, which is red in color. And the most common cause is atherosclerosis. Periarteritis may occur in diseases like polyarteritis nodosa, systemic lupus erythematosus, may cause branch artery occlusion, hematological disorders like protein S deficiency, protein C deficiency, antithrombin 3 deficiency, sticky platelet syndrome, and antiphospholipid antibody syndrome. The artery occlusion may be occur in the form of branch retinal artery occlusion, in which there is sector of the arteries are occluded, giving a visual acuity which is variable depending upon how the macula and the extent of the macula is affected. The afferent papillary defect is mild or absent. There is retinal whitening in the sector which is occluded, and there is arterial narrowing. Again, if you perform fluorescein angiography, there is early masking of the area which is occluded, extreme delay of the arteriolar phase, late staining of the arteriolar walls. A rare incidence is the presence of the ciliary-retinal artery, which is derived from the posterior ciliary circulation and is present only in 30% of individuals. It may be occluded in the form of an isolated phenomena, or combined with central retinal vein occlusion, or combined with anterior ischemic optic neuropathy in elderly patients with giant cell arteritis and with very poor prognosis. If central retinal artery occlusion occurs, the visual acuity is usually no light perception, with afferent papillary defect marked, retinal whitening, cherry rot spot at the macula, arteriolar and venular narrowing, sludging and segmentation of the blood column in the form what we call cattle trucking, as you can see in this fundus photograph, and usually the prognosis is very bad. Usually the patient don't regain their vision except if they are treated very early in the form of paracentesis or inhalation of carbogen, which induces dilatation of the blood vessel. If you perform fluorescein angiography of the central retinal artery, there is early filling of ciliary retinal artery, non-filling of other vessels, with late staining of the vessel walls. If we get central retinal artery occlusion, we have to look for the source of the impulse. We have to perform imaging technique of the carotid artery in the form of duplex scanning, digital intravenous subtraction angiography, magnetic resonance angiography, intra-arterial angiography. The treatment options for the carotid disease include antiplatelet therapy, anticoagulant therapy, carotid endarterectomy with patients with other risk factors for stroke or symptomatic carotid stenosis. Now we shift to hypertensive retinopathy. The third disease, there is arteriolar constriction, which may be focal, generalized, and with arteriosclerotic AV changes, in which the artery, during its passage over the vein at the AV crossing, induces changes in the veins in the form of nicking or deviation. And again, we can get flame-shaped retinal hemorrhage, cotton wool spots, and macular stars, and disc edema. Arteriosclerosis can be graded in the fundus examination from grade 1 to grade 4, in which the arteries appear in the form of silver wire due to the atherosclerotic changes in the wall of the arteries, which prevents us from seeing the blood column during its passage in the artery. Other ocular associations of hypertension include retinal vein occlusion, retinal arterial macroaneurysm, anterior ischemic optic neuropathy, and oculomotor nerve palsy. Other vascular retinal disease include the sickle cell retinopathy, which we should know by name only, not the details, and it passes to peripheral arteriolar occlusion, peripheral arteriovenous anastomosis, neovascularization, vitreous hemorrhage, fibrovascular proliferation and traction, same like the proliferative diabetic retinopathy. We should put it in the differential diagnosis. Again, another important vascular retinal disease is retinopathy of prematurity, and its importance lies in the fact that it can mimic retinoblastoma in a patient which presents with leukocoria or white pupil. It passes through the same stages of any proliferative retinopathy in the form of avascular retina, demarcation line, ridge with neovascular tufts, and these neovascular tufts undergo severe neovascularization, inducing fibrovascular proliferation, retinal detachment, like the proliferative diabetic retinopathy. Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. If we look to the anatomy of the retina is formed of 10 layers on histopathology and depending on the level of the hemorrhage which may occur. Another important disease is Coats disease. It usually occurs in the first decades, more common in boys, always unilateral and present by squint or loss of vision, and with a fine white fundus reflex. It is retinal vascular disease which mimic retinoblastoma, and we have to know. Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. If we look to the anatomy of the retina is formed of retinal arterial microaneurysm, typically affects elderly hypertensive females with localized dilatation of the retinal arteriole, most frequently along the temporal arcade, surrounding retinal hemorrhage, and spontaneous involution is common. Bismillah ar-Rahman ar-Rahim. Today our lecture is about retinal vascular disease. If we look to the anatomy of the retina is formed of 10 layers on histopathology, and depending on, again, the retina can be affected by any blood dyscariasis like hyperviscosity, in which we get venous dilatation, segmentation, and tortuosity, hemorrhage, or in anemia and leukemia, in which we get hemorrhage, cotton wool spots, venous tortuosity, occasionally rough spots, which are very important in the diagnosis and treatment of leukemia for oncology. Bismillah. Retinal disease is radiation retinopathy, in which we get hard edges and small flame hemorrhage in any patient receiving radiation to the head or neck area, increase in hard exudation formation, vascular occlusion, cotton wool spots and hemorrhage, proliferative retinopathy, vitreous hemorrhage, and retinal detachment. It's similar like proliferative diabetic retinopathy or any proliferative retinal disease. Same stages and same pathophysiology. Finally, I want to thank you all.